The Healthcare Labyrinth Podcast is back for another episode. Join Marc S. Ryan, a veteran health plan and health technology executive, as he explores the world of healthcare.
Welcome, everyone, to this episode of the Healthcare Labyrinth Podcast. My name is Marc Ryan, and thanks to everyone for listening in. This week, I will cover the recently issued proposed rule from the Centers for Medicare and Medicaid Services for Medicare Advantage and Part D regulatory changes in 2027. Despite the government shutdown, the proposed rule was issued on time, even a few days early. The rule was very much aimed at reducing regulatory burdens and streamlining regulations, as well as repealing a number of Biden administration initiatives Trump does not like. The rule is expected to be finalized in late March or early April after a comment period that ends in late January. The rule is accompanied by some major requests for information, RFIs, as well. At the end of the podcast, I will also cover new changes to CMS's program audit protocols for MA and Part D for 26. That was also issued recently. We'll take 2 breaks today to help make this more digestible. So let's get right into it. Let's first tackle the 2027 proposed MA and Part D rule. And first up would be star ratings proposed changes. On December 5th, I did a detailed podcast on all the stars changes that were in this proposed rule. Let me give you a quick summary here, but please go back to the 12.5 podcast if you have not listened to it yet for more details. 3 major changes for stars I will mention here are, first, in measure years 26 and 27, star years 28 and 29, CMS proposes to remove 12 measures focused on operational or administrative processes or other measures that no longer show variability in quality among plans. That has the effect of transferring so-called star power to drug measures, Haas survey measures, and quality improvement measures when these measure eliminations are totally phased in. Second, the Excellent Health Outcomes for All, which used to be called the Health Equity Index, is proposed to not be implemented for star year 2027 or measure year 25. That was its first year. The reward factor would be maintained for consistently high-performing plans. Third, CMS also proposes to introduce a new depression screening and follow-up measure that would begin with measure year 27, star year 29. This was expected as universal foundation measures are being rolled out throughout government healthcare programs. CMS says all of these changes could mean at least a quarter of plans would see a drop in star ratings when they are fully implemented. Now let's get into the non-stars changes proposed by CMS for Medicare Advantage and Part D plans in 2027. Let's first cover enrollment, benefit, and clinical oversight proposed changes. First up, a provider network special election period, or SEP. A new SEP for provider network changes is being proposed in the rule, and other existing SEP policies will be codified. If a provider leaves a plan network, an enrollee can change plans to help ensure continuity of care under the proposal. The MA plan and CMS would no longer have to deem the network change as significant. The change is aimed to allow someone to follow their provider to another plan due to in-flight treatment. Next are an interesting prohibition for special supplemental benefits for the chronically ill. This is a relatively new supplemental benefit, SSBCI as we call it, and language in the regulation would be amended to prohibit coverage of cannabis products that are illegal under federal or state law. Third, there's some account-based plan reporting relief. The proposed language would exempt account-based plans such as health reimbursement arrangements, flexible spending accounts, and health saving accounts from creditable coverage disclosure requirements. Fourth, health equity provisions are being proposed to be repealed. The proposed rule would remove requirements for MA utilization management committees to include a health equity expert and for quality improvement programs to include activities specifically designed to reduce health disparities. And fifth in this category, supplemental benefit notification repeal. The rule also proposes to remove the requirement for plans to issue mid-year notices regarding unused supplemental benefits. With that, we will take our first break, and when we return, we will continue with 2027 MA and Part D rule proposals. Be right back.
Health plans and insurance are confusing. Our healthcare system is in dire need of reform. Health policy expert Marc Ryan tackles both issues in his book, The Healthcare Labyrinth. It is both a guide to navigating health plans and fixing American health insurance. Marc dives deep into how health plans and the American health insurance system operate. He then outlines a comprehensive reform agenda for the system as a whole, including pricing, emphasizing health and care management, and ensuring affordable access to health coverage in a private delivery model. Marc is a bit of an unconventional Republican in that he believes affordable access is the morally right thing to do, and that it is also fiscally prudent for our nation. Learn more about Marc's book, The Healthcare Labyrinth, at healthcarelabyrinth.com or search at leading bookseller websites. Available in print, ebook, and audiobook forms.
Welcome back, and we hope you are enjoying this episode of the Healthcare Labyrinth Podcast. We are talking about the recently issued proposed rule for CMS for 2027 for Medicare Advantage and Part D plans. Next up is marketing and related changes. There are a number of changes proposed here. First up, waiting period relief. The rule proposes to eliminate the 48-hour waiting period between completing a scope of appointment form and holding a personal marketing appointment. The proposed rule would eliminate the mandatory 12-hour waiting period between an educational event and a subsequent marketing event at the same location. Other marketing reforms are proposed to bring flexibility as well. Next up is third-party marketing organization reform. Key changes impacting third-party marketing organizations are proposed, including updated language specifying the number of organizations and plans represented, continuation of the TPMO disclaimer verbally during sales calls, and reduction of the required retention period for recordings from 10 years to 6 years. CMS is also asking for input on the TPMO definition and the oversight structure. Next up, superlatives will now be allowed in marketing. The proposed rule also removes the explicit prohibition on superlatives such as best or most in marketing materials, but marketing content cannot be misleading, confusing, or materially inaccurate. Let's move on to some Part D codification issues. So, the rule will permanently codify reforms to Medicare Part D created by the Inflation Reduction Act's Medicare changes. Included in the codified reforms are, number one, the elimination of the coverage gap. Number two, the reduction of the annual out-of-pocket threshold. Number three, removal of cost sharing in the catastrophic phase. Number four, updates to true out-of-pocket cost calculations. Number five, clarification related to specialty tier drugs, reinsurance payments, and subsidy structures. And number six, implementing the manufacturer discount program that replaced the coverage gap discount program. Next, I'm going to turn to requests for information, or RFIs. As I told you earlier, CMS is seeking public input on future modernizations of Medicare. The first RFI they're issuing is on risk adjustment in star ratings program changes. CMS wants broad input on changes to reform and modernize the risk adjustment process and quality bonus payment systems. The risk adjustment request stems from the overpayment controversy at large plans and emerging views that the system, risk adjustment, may discriminate against smaller, newer, and regional plans. CMS may want to migrate to an encounter-based rate-setting system and is soliciting input in this area. Some within CMS also want the STAR program to be budget neutral and not additive in terms of funding. MA has the only quality bonus program that comes from added dollars. CMS also wants to reduce the 2-year time lag in ratings. The second RFI is oversight of chronic condition special needs plans for dually eligible individuals. CSNPs, which are the chronic condition special needs plans, have grown demonstrably over the past 2 years. Dual eligible special needs plans, or DSNPs, were meant to enroll dual eligibles. Those are folks in Medicare and in Medicaid. But more and more are going into the fast-growing CSNPs. CMS is very concerned about this. CMS may want to require state Medicaid contracting for CSNP plans, as well as institutional special needs plans, or ISNPs, to address the growing problem of duals going into other special need plan products. And the third RFI is known as well-being. Coverage of well-being, including preventative care, mental health, and social connections, and nutrition policies, will garner feedback during this third RFI process. It very much matches up with Health and Human Services Secretary Robert F. Kennedy Jr.'s Making America Healthy Again program. Additionally, CMS is seeking public input on a last RFI on approaches and opportunities to streamline regulations and reduce burdens on those participating in the Medicare program, again, through a standalone RFI. With that, we will take our last break, and when we return, we will cover our other topic, the program audit announcement for 2026. Be right back.
The Healthcare Labyrinth is no ordinary website. It features news and commentary from one of the nation's leading healthcare policy and technology experts. Marc Ryan combs the internet for the latest healthcare news and publishes a news feed each weekday with summations and Marc's insights. Twice a week, Marc publishes a blog to go deep into a current issue. And of course, Marc hosts a podcast each week to delve even further. All of this is available at healthcarelabyrinth.com. Visit each day for the latest happenings in healthcare. As well, learn more about Marc's book, The Healthcare Labyrinth, at the website. That's healthcarelabyrinth.com, your go-to source for healthcare news.
Welcome back, and we hope you are enjoying this episode of the Healthcare Labyrinth Podcast. We're talking about the recently issued proposed rule from CMS regarding 2027 Medicare Advantage and Part D changes. We covered all those developments, and now we'll discuss the CMS announcement on 2026 program audit changes, which was also issued recently. On November 20, CMS issued its annual program audit memo to describe changes for 2026. While in the past few years little changed, there were some major developments for 2026. Let's briefly describe them. CMS will continue using the existing 2025 final audit protocols for the Medicare Part C and Part D program audits and the industry-wide Part C timeliness monitoring project to conduct 2026 audits. But CMS did again announce a great many process changes, so let's get into them. Number one, removing audit scoring and redefining condition classifications. CMS began scoring program audit findings based on condition classification back in 2012 in an effort to provide some insights into plan performance. However, since that time, CMS has concluded that scoring on audits does not fully reflect a sponsor's audit performance or how the sponsor is performing overall. Thus, CMS is making several changes related to the classification of findings and scoring in program audits beginning in 2026. CMS will remove scoring from audits, and conditions will no longer have a point value associated with them regardless of classification. CMS also is removing the classifications of immediate corrective action required, ICAR, and observation requiring corrective action, ORCA. While CMS continues to support the concept that some noncompliance requires corrective action to be taken more quickly, CMS understands it may not be feasible for sponsors to develop a full and comprehensive corrective action plan within 3 business days of notification. I heartily agree, and I think that's a good change, although plans should intervene when a major noncompliance is found. With the removal of ICAR and ORCA classifications, CMS will simplify its analysis of noncompliance. For 2026, when noncompliance is identified on audit, CMS will determine if correction is needed to either prevent a recurrence or remediate impacted enrollees. If correction is needed, the condition will be classified as a corrective action required, CAR. If CMS determines that correction is not needed, the condition will be classified as an observation, a much simpler process that CMS is proposing here. Additionally, CMS will continue applying the invalid data submission classification when a universe is deemed inaccurate or invalid and CMS cannot determine compliance with requirements as a result. On compliance program effectiveness, one of the protocols, CMS is shifting its audit approach to be more consistent with how compliance oversight is actually conducted by sponsors. CMS will pilot this new approach for reviewing CPE during the 2026 audits. While reviewing other program areas of the audit, CMS will have in-depth discussions with the sponsor about how it prevents, detects, and corrects noncompliance related to the audited program areas, and how the compliance program impacts the sponsor's ability to comply with CMS's requirements during the course of conducting business. In addition to piloting a new CPE audit approach, CMS will begin hosting quarterly education calls with industry compliance officers. The purpose of these calls will be to share information about compliance issues detected during CMS's program audits. CMS will also streamline audit follow-up. In the past, CMS required sponsors to hire an independent auditor to validate if deficiencies found during an audit were corrected and not likely to recur. In 2026, for the most part, CMS will dispense with validation audits and work directly with plans to validate corrective actions. More complex findings, however, will still be subject to testing through a full validation audit. CMS also updated on the 26 schedule. CMS will send scheduled program audit engagement letters to sponsors starting in February through August of 2026. To reduce burden and promote efficiency, CMS will continue conducting audit fieldwork across 2 weeks. Due to the changes in CPE, the other audited program areas will be spread out within these 2 weeks, which should alleviate some of the burden in those areas. All audits involving Part C will continue assessing compliance with the coverage and utilization management requirements finalized to ensure Medicare Advantage beneficiaries can access medically necessary services without excessive burden or delays. This was a new requirement in the last few years. CMS is still suspending collection of Formulary Administration Table 3, Prescription Drug Event, CDAG Table 7, Comprehensive Addiction and Recovery Act, CARA, at-risk determinations, and ODAG Table 6, Dual Special Needs Plan, Applicable Integrated Plan Reductions, Suspensions, and Terminations. With that, we will conclude this edition of the Healthcare Labyrinth Podcast. See you next week. Take care.
Thanks for joining Mark and the Healthcare Labyrinth Podcast. Go to healthcarelabyrinth.com each day for the latest healthcare news. See you next week on the next Healthcare Labyrinth Podcast.